Okay, substance-related disorders, 7th edition, chapter 25. Here are some thoughts for you as we begin to discuss one of the most emotional topics, because whether or not you have personally had conflict with a substance disorder, I'm sure that you know someone or have a family member or a loved one that it has affected in some negative way. So everybody knows a little bit about the kinds of things that can happen to a family unit and to an individual who gets caught up in some, decisions that involve drugs or alcohol or other substances. So here's some thoughts to ponder. This is not a test question, but I just found it quite amusing. Alcohol is classified as a food. Who knew that? Who did? Somebody said I did. I'm worried. Okay. It's classified as a food because it does contain calories. However, it has no nutritional value, so all you can get is fat, okay, and drunk. Whiskey dates back a very long, long time. Historically, the word whiskey meant water of life. So, okay, those are true stories. They're in your chapter, I promise. In the past, and I found this very odd, but you guys have an edition of the medical surgical book that is an older edition. They've gone to a new edition. So as I was going back to compare these lectures, you have an entire chapter in your med-surg book. The new edition has 2 pages of substance abuse in the new med-surg edition. So to me, I found that to be a little bit disturbing, since it seems to be a bigger problem. Substance abuse seems to be growing, not declining. However, the med-surg book that you have has quite a bit of information, and the new edition has 2 pages. So I don't know where that's going in our field, but substance-related disorders. Okay, well, when we talk about those and we lump them together, there's 2 categories of that, or 2 groups, if you will. The first group is the substance use disorder, which includes dependence and abuse. The second group is the substance-induced disorders. So when you think about something being induced, it's caused by, right? Okay, so the second group includes things like intoxication, withdrawal, delirium, dementia, all of those things that are associated with the use and the abuse of the drug. So you got those 2 groups. One, as I said, is the substance use disorder, and the second is the substance-induced disorder. Okay? The substance-induced disorders also, I didn't mention, but also do include dementia, amnesia. These are all listed in your book. Psychosis, mood disorder, anxiety disorder, sexual dysfunction, sleep disorders, whatever comes as a result of or is induced because of substance use or abuse falls in that second group, second class. Now, we could talk probably for the next 3 days on substance disorders, but we're going to limit the topics to the ones listed in Chapter 25. Not that that's inclusive of everything, because it's not, but that's where we have to stop for testing purposes for this semester. I know y'all are happy about that. Okay. We're going to spend time talking about dependence, abuse, intoxication, and withdrawal from several different classifications of substance. These are all clearly defined for you on pages 456, 457, and 458. In those tiny little core concept blue boxes, it gives you the definitions of each. You'll need to be familiar with those. According to genetics, the child of an alcoholic parent, one parent, is 3 times more likely to have a problem with alcohol use. So it stands to reason if they're born to 2 alcoholic parents, they almost don't have a chance at all of not becoming some type of substance abuser, likely alcohol. There's a wide variety of substances that, we have on the market that do great things. I'm not saying that, drugs are all bad, stay away from them, taboo. No. They control pain. They control nausea. They do wonderful things, but they are put into context and boundaries for safe use. It's those contexts and boundaries that get blurred when it becomes a substance abuse or use disorder. When we talk about substance abuse and use, it's not only prescription. There are a lot of over-the-counter substances that can be abused. A lot of laxatives are abused. A lot of cold medicines are abused. So it's not specifically limited to a prescription medication that we're talking about. Illegal substances are becoming much more widely socially acceptable. If you talk to most of your, even middle schoolers, they will tell you that marijuana is a safe drug. Well, out of what we've introduced to them now, it may be one of the safest drugs to abuse. Hashish, that I didn't really know what that was, it's a cannabis flower and resin. So hashish is just a more stronger, potent form of marijuana. Same plant. They do have side effects that we still don't understand the long-term uses of. They're still evaluating those long-term uses and side effects with marijuana. They're not so much documented like we have with cocaine or with LSD. Those side effects have been documented for years, and there's none of those that are positive. They have no positive outcomes. Social drinking is a big deal and begins much earlier now than you would have thought. Social drinking statistically becomes a really big part of a curriculum or activity at age 12 now. Okay, those of us with children just went, ah! Nicotine use, they don't think twice about it because they don't see nicotine as being a drug. They sell it at Walmart. They don't see nicotine as being a problem. Caffeine is a drug. Okay, how many's overdosed already today? Okay, 2 hands. Gotcha. No, really, we'll talk about how much caffeine puts you in overdose. And when you start looking at the labels of what you're drinking, your energy drinks, you're probably going to go, wow, I had no idea I was doing that to my central nervous system every day. Substance-related disorders are diagnosed more commonly in men. I didn't say they happen more in men. I said they're diagnosed more commonly in men. We're also going to talk a little bit about codependency. We're going to talk about substance abuse within the nursing profession, healthcare professionals, the chemically impaired healthcare professional. The DSM criteria for substance abuse, substance dependence, substance intoxication, and substance withdrawal all vary just a little bit. A lot of them will overlap, but then there are some subtle differences. And so we're going to talk about each one briefly. But the DSM criteria for each one of these begin in your psych book on page 456. Now the topic heading for this slide is criteria for substance use disorders. I think for future reference I'm going to change the word use to abuse because that's really what we're talking about, right? We're talking about criteria for substance abuse disorders, and that's how it's listed in your 7th edition, page 456. Abuse is the use of any substance in a way that it is not intended to be used or to be used in a harmful way that results in injury or hazard to your health. So, we really, a lot of the times, abuse very simple medications. Tylenol, if that didn't work the first 2, take 2 more. Take 8 ibuprofens. You know, that's not how it was designed to be used or safety measures, but we do. So when you think about that, that is abuse of a medication right there. Maladaptive patterns of substance use that is manifested by recurrent and significant adverse consequences specifically related to the continued use. The continued use, what I just said, means the continued use of this substance causes bad things to happen, bad consequences and health problems and fights with your loved ones or legal issues, but there's a continued use. in spite of these negative consequences. That's the maladaptive pattern that begins to evolve when there is substance use and substance abuse that begins. Obligations such as work responsibilities, social promises, poor performances at work, school, home, those all begin to become evident as that maladaptive pattern continues to unfold. A hazardous use is a use that results in impaired cognitive ability, poor decision making, not only putting themselves at risk for danger, harm, or death, but everyone else around them with no regard to that consequence. We're talking about people who get behind the wheel of a vehicle and they are chemically impaired. Not only have they put themselves in jeopardy, they put everybody in jeopardy that they come in contact with. Operating heavy machinery. What about our chemically impaired health professionals that put people to sleep and go in and perform surgeries and are chemically altered? It's happening. Recurrent legal problems such as DUIs, DWIs, stealing to support habits, lying to cover up the episodes. The use causes significant problems with the user and their family, their loved ones, friends. How many of you have acquaintances that used to be a lot of fun when you went out with them and now you avoid them because they don't know when to say stop, they don't know how to act appropriate, they're always in trouble, enough is never enough. So you kind of start to shy away from those people. And so they lose their support system all the way around, which is going to lead to some different outcomes that we're going to talk about. The user creates excuses for their continued use. They will continue to use despite having these arguments with loved ones, despite the unfavorable consequences that are the outcome. They will begin to look physically deteriorated because of the use of these drugs and substances. The DSM, to classify someone as being the user or substance abuser, uses a 12-month period of time. It uses that 12-month period of time to evaluate behaviors to determine the substance abuse, to what degree. And one or more of the criteria that we've just gone over occurring within a 12-month period might fall under the DSM criteria for substance abuse on page 456. Substance dependence. It wouldn't be uncommon for substance abuse to lead to substance dependence. If you're using something in a way it should not be used, your body begins to react differently to it than what was the intended reaction. The need to use for a substance-dependent person becomes very compulsive and very chronic. The use of this drug becomes so consuming of this individual and so strong that without that substance, the user actually physically and emotionally begins to feel great distress until that substance is obtained and used. The substance causes great difficulties in all areas of their life. They continue to use it. They have to continue to use it to avoid that distress and those unpleasant feelings that are associated with what's going into a withdrawal syndrome. Depending on what the drug is and how much of the drug and how long they've been using it, the time frame for going into withdrawal or withdrawal symptoms varies. So to avoid going into that withdrawal syndrome, they have to find that drug. And those feelings are so unpleasant and so strong, that takes over everything else they can think about. The user becomes psychologically dependent. They become physically dependent as the need for increasing the larger amounts of this substance and the more frequent use of this substance becomes required by the user in order to obtain that same desired effect that was originally produced by a much lower dose. Why is that? The tolerance. With repeated and frequent use, you build a tolerance. So, drug abusers, substance dependence people, when you talk to them about it after they have begun a program and they've begun to clear up a little bit and be able to think a little more clearly, they'll tell you they're always chasing that first high. The first time that they use it, it is immense euphoria, relaxation, intense pleasure, and they're always looking for that again. And it takes more drug, and they're always looking for that first initial response that they don't find. But it takes more and more drug to get close. You can classify an individual as being a psychologically dependent when there is an overwhelming desire to repeat the use of the drug to stop the discomfort they're feeling. So when they have to repeat the use of the drug to stop the discomfort they're feeling or to avoid the discomfort and to produce a pleasurable outcome, they're dependent on that drug. Again, those are very powerful and intense cravings, and they do create compulsive use of the drug. Dependence is also called addiction. That was an older term. That's a more community term. It means the same thing. The users experience unpleasant behavioral changes, even when they're using or when they're not using. Loss of control over the drug, loss of the control over taking the drug. Now they have to take it. They may have medical issues as a direct result from taking the drug, things like gastritis, depression, anxiety, irritability. Even with all of these medical problems that they're causing by using the drug, they're going to find that drug so that they can use it. The DSM for a substance dependence uses a 12-month period again, and at least 3 of these criteria that we have just discussed needs to be present to be classified. The drug use is going to alter the user's lifestyle, their personality, their friends. People who don't want to hang out with them will find something else to do, and they're going to end up with people that don't judge them for what they're doing. Why? Because they're doing the same thing. They're going to end up hanging with people who don't judge them because they're doing the same thing. So their entire circle of friends begins to change. If this helps to ease their guilt that they may feel in the beginning, they feel like they belong with this other group of people. It feels like a support system to them, but it's not. Those other individuals are using too, and they don't care about that individual. They just care about the drug and getting high. And if you're going to hang out with them and y'all can go together to find this drug, well, that's all well and good, but I'm not going to stop you from overdosing. When they hang out with that type of people, though, they've begun to stop making excuses. They don't have to create a time in which they can go out, or they don't have to be very creative in why they were drinking or why they were, wherever they were at, because they don't have to make excuses with those people. The use of the drug then becomes their all-consuming thought. And the use of the drug causes substance intoxication. We're on page 457 now. A reversible substance-specific syndrome that's caused by a recent ingestion or exposure to a substance. So recent ingestion or exposure causes substance intoxication, and we did say it's reversible. It causes behavioral changes from the physiological effects that the drug has on the central nervous system. These effects begin to develop shortly after the use of the drug. Some examples your book gives are belligerence, labile mood, very emotional, cognitive impairment, poor judgment, impaired social functioning, impaired occupational functioning. There's a difference in the substance-produced activities that they're going through, those different physiological effects. Some of the drugs may cause very different reactions. Some of them may cause a blurry, similar reaction. And some drugs may cause identical reactions, even they're different drugs. So a different substance can produce a similar or an identical type of syndrome. The bottom line is that the symptoms are not due to a general medical condition. The symptoms are due to the intoxication or the ingestion or exposure from that substance, not from a medical problem. Sometimes people have medical problems that cause labile moods or irrational emotional swings or belligerence, and that's not what we're talking about. These effects, physiological effects, are specific to the ingestion or the exposure to a substance. Intoxication, yes. I did not say it doesn't apply to nicotine. As I said in the beginning, nicotine is a drug, caffeine is a drug, so substance dependence and substance withdrawal. In the book, it says it does not. Well, I think that it does because I think that would be a misnomer. I don't know the answer to that because in the past nicotine has been classified as a drug and nicotine has very much been classified as withdrawal and addiction and dependence. So if the book says this does not apply to nicotine, then that's what we're going to go with. It does not apply to nicotine according to the book and for testing purposes, and I will have to research that answer. But thank you for pointing it out to me. I do not know why it doesn't. Didn't get to talk about this slide, did we? Substance withdrawal. Heavy and prolonged use of a substance. Usually this is going to go hand in hand with substance dependence. Physiological and mental readjustment that accompanies the discontinuation of an addictive substance. So if we stop this drug, whatever that drug of choice is that we've been talking about, if we stop it, or sometimes even significantly cut back on it, your client will go into substance withdrawal. It causes a clinical distress, grief and impairment in social and occupational and other areas of functioning. These symptoms that are produced from the withdrawal of the drug are not because of anything else, not a general medical condition, but because that drug that has been so consistent in their blood for such a period of time has been withdrawn or decreased. And the body's literally craving, and you get those changes. That irritability, belligerence, mood change. The diagnostic criteria for substance withdrawal is on page 458. The incidence of substance abuse, substance addiction. It is the #1 preventable health problem in the United States. Abuse and addiction is the #1 preventable health problem in the United States. And alcoholism is the 3rd leading cause of preventable deaths in the United States. And as you've all just finished studying cirrhosis of the liver from last semester, you know how many different ways that alcoholism has a toll on the body. Patterns change, vary a little bit according to the demographics, age, sex, sociocultural background, size of the patient, changes according to whether or not there's food in the stomach upon ingestion of different drugs. The French culture and the Italians seem to have the lowest alcohol abuse rate, and they relate this to their social norms and cultural norms because it's more early accepted as a younger child, and they learn to respect it more, and they build up tolerance more, and for whatever reason, they don't go hog wild as our American kids do when they get out from under our thumb, I guess. I don't know. Polysubstance use. The higher amounts of the drug available gives an easier access. They can get it. Don't think they can't. It's out there. There are great numbers of drugs now that are being created and introduced to our younger children as gateway drugs that we'll talk about a little bit. If there's a will, there's a way. They can find it. Polysubstance, that is a term used for someone who abuses or takes in more than one substance at a time. And they have now these farm parties. Those are classified under your raves and your techno parties. Skittles parties. Everybody goes home and finds drugs in their medicine cabinet, prescription drugs for grandma, dad, Aunt Margaret, whoever. And everybody brings some of the drugs to these parties, and they all put them in a large bowl and mix them up. They look a lot like Skittles in the bowl, all the different colors and shapes, and these kids don't know what they're taking. They have no idea. We had a 12-year-old who took some really strong blood pressure medication, April, bottomed out at the party, and could not be resuscitated at the emergency room because someone brought blood pressure medications and put in this bowl, and the kids are like, "Oh, this one's pretty." Our kids are not educated, or just they're not getting it somewhere. I don't know. Half of Americans 12 and older, half of the Americans 12 and older report being current drinkers. And of that percentage, 1/5 of them report being binge drinkers that consume large amounts of alcohol every weekend. Half of our 12-year-olds. What do you think about that? You think that's an accurate assessment? Lowballing? What do you think? Okay. The gateway drugs, these are the drugs that I mentioned just a while ago about, they are aimed at your middle schoolers. These are the drugs that are targeting the younger children, the youth, the middle school ages. They do this by making them and then covering them with a bright, pretty color. And they'll even go as far, the drug makers will even go as far as to stamping them with cute little innocent pictures that even make them look more like candy. And they'll go and they'll stand around places where these youth populations are, and they'll hand out 2-3 times for free. Well, it only takes once for the majority of our children to want to come back and take that again. So the first few times, they're just passing them out, and they're cute, colorful, innocent looking, maybe even packaged. And they'll come back for that drug. These are the drugs that will lead to harder use later on. These are what your book calls your gateway drugs. Now, who grows up to want to be a substance abuser? Nobody I know has ever said that. I'm going to grow up to be an alcoholic. Woo! No. So what makes this? What creates this person? There is no one single theory that's going to explain fully why someone becomes a substance abuser. It requires various elements working together in determining a person's susceptibility to abusing substances. And some characteristics of a person will predispose them to becoming dependent on substances. There are apparent hereditary factors, especially true with statistics on alcoholism. There are some twin studies, and you can read over those on page 458, talking about monozygotic and dizygotic twins born to alcoholic parents, and how that even if they are separated at birth, or even if they are adopted at birth, they still have the tendency to become alcoholics. So it's not just the nature-nurture. It has to blend into both areas. Alcohol itself is an addictive substance that is compared to the way morphine reacts in the brain. It has a morphine-like substance reaction in the brain, making it addictive. To diminish the unconscious anxiety, diminishes increasings of guilt, shyness, You know, the little person who was too shy to go to the party, and they just begged and begged and begged, and after that first beer, they were the life of the party. Yeah, it turns off those inhibitions and, you know, kind of, puts it in overdrive. It makes them feel good. It makes someone with low self-esteem feel powerful. Feel like, you know, they got all these friends around them. They don't realize all these people are standing around laughing at them. They just realize they got all these people standing around them. You know? Makes them feel accepted. And I said about the characteristics, there are certain characteristics that statistically predispose someone to having that addictive personality. Low self-esteem, depression, being very passive and following the crowd, a lot of peer pressure, giving in to that. Someone who has a higher level of anxiety at a young age. All of those characteristics do predispose someone to being a substance abuser. Children model their environment. Believe that? Absolutely. And they're going to model that good and that bad. You can't tell them how to act and then show them a different way. Right? That doesn't work. You can't tell them not to abuse drugs or take candy from strangers and then sit in the living room smoking pot. Okay? They're going to model that behavior, whether you set a positive or a negative influence for them. Substance abuse is also associated in a high correlation of antisocial personality disorder diagnoses. I know you haven't had that yet, but it just goes with that type of diagnosis, antisocials. Conditioning, if you read through the conditioning part of the theories, it says that if a drug depresses the central nervous system and it produces that relaxed feeling, it eases that tension and anxiety and that nervousness related to social settings or related to, you know, having to get up in front of a crowd or whatever it is they're feeling that anxiety over. Yeah, I didn't do any before I came in, I promise. But whatever that social setting is that they're feeling anxiety over, it reduces all that. And if a drug does that for the individual, then we're conditioning that individual to use it again if there was a positive outcome. If they used the drug and they were able to fulfill their obligation and then they got up in that social setting and they did okay and everything went well and they felt good and people seemed to like them, we've conditioned them to want to use it again, right? So that's the conditioning theory on that. Alcohol is a CNS stimulant or depressant? Depressant. They think they feel great. They think they have energy. They think they are going all night. But alcohol is a CNS depressant. Our culture, some of our cultures will establish patterns of substance abuse by very early on molding their attitudes, influencing them, showing them consumption. Sometimes consumption is based on cultural acceptance. Some cultures, like I said earlier, it's perfectly fine for people much younger than 21 to engage in alcohol intake. Native Americans have an extremely high incidence of alcoholism and dependency. That is one culture that has a lot of supportive statistics in that area. Native Americans have a death rate from alcohol that is twice that of the general population.
Why is that? Because even when I was a girl, in the old Western movies, they never gave whiskey to the Indian.
There is a very high correlation of alcohol abuse on the Native American reservations. I don't know why that is culturally acceptable, but it is. And it is an incidence that has been documented twofold. They have a very high rate of death from alcoholism. Also, some geographical regions will make a difference. For instance, alcohol dependency is a lot higher in Northern Europe than it is in Southern Europe. Why is that? I don't have the answer to why. It just is. There are some other social considerations and cultural considerations if you want to read over them on page 459. I don't plan on asking you something as specific as, is Northern Europe or Southern Europe higher for alcoholism? That's not something I think you need to know. You need to know what happens in the body. Families Families of these users usually will make excuses for them. They will follow through with obligations that the user didn't follow through with. They'll make an attempt to be supportive for a while. Our phases of alcoholism is on page 461 and 462. These are important. I do think you need to read over them and familiarize yourself with how alcoholism phases unfold. The pre-alcoholic stage starts as a social drinker. All these things we've just been talking about. Start drinking to be funny. Start drinking to decrease the anxiety. Build some self-esteem. Want to feel belongingness or accepted. A lot of your alcoholics will tell you, well, in the beginning I drank just to let go. Just to, kick back and chill. They begin to drink more often. They begin to drink more than others around them. They got 2 drinks for every one of yours. And they think they're in control. They still appear to be in control. And most of the time, these are your children from alcoholic parents. The early stage begins when they begin to have blackouts. And do not confuse blackouts with passing out. Okay? A blackout is a period of time they are still going, active, talking, interacting, and they have no memory of that when they sober up. Okay? So, in the early stage, blackouts begin. Historically, people kind of considered blackouts to be somebody who'd been drinking a long time and a lot for a while, No. This is usually, these blackouts is the first sign that they're beginning to abuse alcohol. They begin to stash it, sneak it, gulp it, hide it. Chronic hangovers, but they won't stop using because right now they can't. They will begin to use an alibi system. They'll start working out and rationalizing where they're at and what they're doing and why they're, doing it. Start coming up with creative ways to use situations to manipulate them to drink. They'll give reasons for why they're drinking and deny that they have a problem. Their behavior pattern for drinking begins to change, and it's not so much social. They begin to drink alone. They begin to drink daily. And they begin to look for those environments to drink in, where it's acceptable. They will try to self-impose rules on their drinking. They'll say things like, I'm only going to drink so many. I'm only going to drink 3, and that's it, all night. That's it. 3 turns into 5, turns into a blackout, and who knew how many you drank then. The old saying used to be, 1 drink, drank, drunk. And they don't realize it, because that 1 drink is just enough to get them going. What is it Alan Jackson says? It's 5 o'clock somewhere, right? So they look for that excuse. Somebody said that up there? They no longer drink because it's pleasurable, but the alcohol is now required. And we're still in the early stage, right? All right, so in the crucial stage, they completely have a total loss of the control to choose whether or not to drink. They must drink, whatever the cost is. Family, fights, lose their job. They may go on these binges that last from a few hours to several weeks. During the time in which they're binging, they don't eat. They don't meet their hygiene needs. They're very irresponsible. In In the crucial stage, this individual usually always has a hidden stash. They have always gotten something to rely back on. They will protect that supply. They will go to great lengths to hide it, making sure that they've put it somewhere nobody would think to look. Physical and mental deterioration becomes very evident in this client. They have poor health, weight loss, poor nutrition, may have tremors. They begin to develop those GI problems that we talked about, the body, liver problems. At this point, they can promise you all day long they're going to stop. They do feel guilt, and they do have stress and anxiety related to their drinking, but when they promise you to your face they're going to stop on bended knees, bawling and squalling, they will leave to go find a drink to decrease that anxiety and stress level that they are feeling, to get rid of the guilt that they're experiencing. And chronic, in your chronic stage 4, they are completely dependent. They are chemically dependent on this alcohol. They are helpless and hopeless at stopping on their own. And they just begin to feel a lot of self-pity. May or may not have lost everything that meant anything to them at this point. They stay intoxicated more days than they are sober. May or may not experience psychosis, impaired reality. Those physical problems start to take over. They may become physically ill now. But without the alcohol, they experience these terrifying withdrawal symptoms, some of which can include hallucinations that are very vivid and very real, tremors, even convulsions, seizure activity, severe agitation and anxiety, panic, depression. All of these are not uncommon. Okay, let's take a bathroom break. Let's take about 5 minutes and come back and pick up. Okay, alcohol abuse. As the individual begins to drink, it does decrease the cortical inhibitions. So in the brain, their inhibitions do become decreased. There is a change. We did say it was a CNS depressant. 20% is absorbed directly and immediately through the stomach wall and goes straight to the bloodstream. So out of that drink, 20% straight to the bloodstream. Alcohol does not go through a process of digestion, so it slows down your brain activity. The other 80% then of that drink is absorbed only at a slightly slower pace through the upper intestinal tract and then goes straight to the bloodstream. We've talked about it produces that relaxing effect, those loss of inhibitions, a lack of concentration follows, drowsiness, slurred speech, sleep. These are the results of alcohol intake in what is to be considered a low dose of alcohol intake. That's kind of the general way it plays out with someone drinking a low dose. There are a lot of different effects on the body from drinking. Those begin on page 462. It covers peripheral neuropathy, alcoholic myopathy, Wernicke's encephalopathy, Korsakoff psychosis, alcoholic cardiomyopathy, esophagitis, gastritis, pancreatitis, all your itises, alcohol hepatitis, cirrhosis of the liver. Most of these we've talked about last semester. Leukopenia, thrombocytopenia, and sexual dysfunction. Now you can read over those. I'm only going to say a very small, brief statement on each of them, so you are welcome to read over them in more detail. Peripheral neuropathy is a peripheral damage to the nerve causing pain, burning, tingling, prickly sensations in the extremities. It is because of the decreased vitamin B, particularly thiamine, that tends to be a problem with consumption of alcohol. Your alcoholic myopathy, now this can be either acute or chronic. It involves muscle pain, swelling and weakness, red tinged urine. The reason the urine is red tinged, it is myoglobin that's being excreted from the muscle breakdown. So if you think about an alcoholic, they're not looking healthy, right? They don't look healthy. Their muscles literally are beginning to break down, and the myoglobin is being excreted through the urine in an alcoholic myopathy. They have a lost muscular enzyme, which is increased in the blood. When they're chronic, there is a term of muscle wasting. They just begin to shrink away. Their muscles just look like they're deteriorating. They don't have any pain associated with this, and they don't have any elevation of enzymes associated with alcoholic myopathy. Your alcoholic cardiomyopathy, this is an accumulation of lipids in the myocardial cells.
Now, will that be because it does say the creatinine is elevated?
Your creatinine is elevated?
Yes. And that's some of the tests.
In the cardiomyopathy? Yes, that's correct. Wernicke's encephalopathy, again, this is a thiamine deficiency. You're going to see a lot of thiamine deficiencies when we talk about alcoholism over and over and over. Korsakoff psychosis, this is confusion, a loss of memory, confabulation. You remember what confabulation is, right? They just make it up as they go along. Why do you think they're making it up as they go along? They don't remember. They were having blackouts. Yeah. Inflammation of the esophagus, the stomach, the pancreas. You just got all these problems. Alcoholic hepatitis, that's the inflammation that occurs in the liver from all this drinking. Cirrhosis of the liver, of course. Alcohol is the cause of cirrhosis. It's the end stage of alcoholic liver disease. If you don't remember what the complications of cirrhosis are, refer back to page 463. Leukopenia, thrombocytopenia. When we talk about sexual dysfunctions, men seem to have a decreased libido and sexual performance and impaired fertility. Women have changes in menstrual cycles and decrease or a loss of the ability to even become pregnant. It does reduce the levels of testosterone and estrogen. So I guess you could say alcohol affects both genders without bias. It's going to mess both of us up. I know that fetal alcohol syndrome falls next in your book. It's on our next slide. Just hold that thought. So we're going to skip over that in the book until the next slide. On page 465, we're talking about symptoms of intoxication and symptoms of withdrawal. This is related to the blood alcohol levels. Intoxication usually occurs at 100 to 200 milligrams per deciliter. And you are legally intoxicated at 0.08. Death has been reported at 400 to 700 milligrams per deciliter. Why do you think there's an increased risk with consumption for OD? Because of the tolerance. The tolerance increases. The problem with that is the tolerance increases, but the physical dependence or the physical symptoms don't decrease. So that respiratory depression continues to increase as well with the increase in central nervous system depressants. Your withdrawal symptoms begin usually within 4 to 12 hours of the last drink, or may be experienced with just a reduction in the amount of alcohol that they've been taking in for a period of time. Especially if they've been a very heavy drinker for a prolonged period, and they're used to consuming, let's say 18 beers a day, and now today they have no way to get anywhere and no money to buy anything, and they only have a 6-pack left, and they drink the 6-pack, they can still go into a period of withdrawal just from that decrease in the amount that they're used to. Does that make sense? Okay. Your withdrawal syndrome, it does involve many of the symptoms, and it can progress pretty rapidly to alcohol withdrawal delirium. You're going to hear a lot of these said again when we talk about mood disorders. Mood disorders tend to mimic the conditions of alcohol intoxication and withdrawal symptoms sometimes. And it sometimes will mask other true conditions. The onset of the delirium is usually on the second or third day following the last drink of alcohol or following that prolonged reduction in alcohol intake. They become very restless, confused, may have nightmares or hypersomnolence. Okay, now back up to the fetal alcohol syndrome on the previous page. This is actually a new addition to the notes from previous semesters. We've added fetal alcohol here. As your slide says, it is prenatal exposure to alcohol. There is no safe amount of alcohol consumption during pregnancy. Alcohol can damage a fetus at any stage of pregnancy. You hear all of the old wives' tales, oh, when you're in your third semester, it's okay to drink. No, it's when you're in your first semester, before they start developing, it's okay to drink. It's not. It can cause damage across the entire pregnancy to the fetus. When you take neuroimages of these children with fetal alcohol syndrome, there is abnormalities that will show up in the size and shape of their brains. So it does cause significant problems. These fetal alcohol syndrome children do require lifelong care and treatment. The prenatal exposure to alcohol results in a broad range of the disorder to the fetus. It is these disorders, however many of them are existent or this child may have, but it is that range of disorders that are known as fetal alcohol spectrum disorder, and that's what we refer to as fetal alcohol syndrome. It's the same thing. Whether you say fetal alcohol spectrum disorder, fetal alcohol syndrome is usually the type of spectrum disorder that you're talking about. It includes both physical and mental behavioral changes, learning disabilities. There are problems with memory and attention span, problems with communication, hearing and or vision, or a combination of any of these. Fetal alcohol syndrome accounts for 1.2 to 1.5 in every 1,000 live births. But there is a higher rate among African Americans and Native Americans. The rate of fetal alcohol syndrome among those two are 9 in 1,000 in Native Americans. I'm sorry, that's not for the African Americans. It is higher in African Americans, but the rate for your Native Americans is 9 in 1,000 live births. But that shouldn't be a shocker, considering that we've talked about how much higher the drinking rate and alcoholism statistics are for your Native Americans. Not every child born to a mother who drank during pregnancy will have fetal alcohol syndrome. So there is a lot higher incidence of pregnant women who are drinking than we have fetal alcohol syndrome children that are born. But really, is that the risk you want to take? Their frontal lobes of their brain and their cerebellum are much smaller than normal children. Fetal alcohol syndrome also affects the corpus callosum and the basal ganglia. Well, my goodness, that's nearly the entire makeup of the brain. Fetal alcohol syndrome children are also at a very high risk for psychiatric disorders. Most commonly ADHD, mood disorders, anxiety disorders, and alcoholism. There is no cure for fetal alcohol syndrome, but it is 100% preventable. All right, we move into sedative, hypnotics, and anti-anxiety as we talk about the substance disorders. Your pharmaceuticals include our barbiturate, non-barbiturate, sedative hypnotics, and benzodiazepines, which are also anti-anxiotics or anxiolytics. There's a narrow range between the therapeutic and the toxic levels. Why does someone use or become addicted to this kind of substance? Well, it's a lot of the same reasons why we talked about someone is becoming addicted to alcohol. Overdose on this classification of medications causes cardiac and respiratory arrest. There is a table, table 25-1. It has a list of drugs that are commonly associated with this category. Barbiturates will decrease the central nervous system. We talked about what happens when the central nervous system is depressed. They get that relaxing, sleep-producing, decrease in anxiety, decrease in respiratory rate. Abusers take the drug to maintain that state of free living with no anxiety. Really? Okay. They develop a tolerance, as I said, to the physiological effects, but the body itself does not develop a tolerance to the respiratory depression effects. Those continue to get worse with increased amounts. It takes more of the drug to equal the same level of pleasure. More of the drug causes more respiratory depression. Hyperexcitability occurs with withdrawal of the drug. Anytime you take more than one of these drugs in this category or classification and combine them together, or take the drug and combine it with the effects of alcohol, obviously the end result is much more higher rate of respiratory depression, cardiovascular. They build off of each other, so their effects are much greater than alone. Psychological dependence. This is described as a psychic drive or crave for the drug. 15% of all people in the United States have had a benzodiazepine or an anti-anxiety anxiolytic drug that was prescribed to them by a medical doctor. If you've ever had surgery, 90% of our surgical patients had something out of this category given to them during a surgical procedure. On page 465, at the bottom, number 4, it talks a little bit about cross-tolerance and cross-dependency. This just means that when your patient is experiencing cross-tolerance, one of the drug results in causing a lessened response from the other drug. That's a cross-tolerance. And a cross-dependence is a condition in which the drug prevents withdrawal symptoms associated with that physical symptoms that we talked about when the drug's taken away. So we can add another drug in its place. That's how they sometimes will titrate your addicted patients down, or will choose what is considered a safer drug than the drug they're addicted to. Withdrawal symptoms listed here on the slide. These symptoms are usually very severe. They can be fatal. The withdrawal symptoms, I believe, begin within 8 to 12 hours of the last dose of whatever medication it is that they're addicted to or using. There are two patterns of dependency and abuse. Two patterns of dependency and abuse. And that's on page 467. The first pattern is when the individual has an MD prescription for some type of CNS depressant as a treatment, like we just talked about all those surgeries, right? 90% of surgical patients left there with a prescription of some type of central nervous system depressant. And the patient then took it upon themselves to either increase the dose or to increase the frequency because they began to build up the tolerance and they kind of start to depend on the drug and like the drug. Even though the pain they were taking it for probably is decreasing, the need for the drug is increasing. So that's the first pattern of a drug abuse or drug dependency. The second pattern And your book says this is even more frequent than the first pattern. And we said 90% of people leave there with that prescription, right? So this one, the book is saying, is even more frequent. What happens is that it begins in the teens and early 20s with peer groups, and they obtain these drugs illegally to get that feeling of euphoria, that high. And then they actually will combine the drugs, more than one of the same, benzo, non-benzo, or barbiturate or non-barbiturate or a benzo, combine the two, or add alcohol. So when we talk about our CNS depressants, high abuse potential, the withdrawal symptoms can be life-threatening. Those are on page 468. Usually the withdrawal symptoms are associated with high dose levels and for longer periods of time. But that is not always the case. There are documented cases of moderate drug dosages for shorter periods of time have caused withdrawal symptoms, withdrawal syndromes. Table 25-1 on page 466. Listed for your barbiturates and non-barbiturates, that Valium is a benzo. It's one of those anti-anxiety or anxiolytics. So is Librium. Amytal is a barbiturate. Seconal is a barbiturate. And Ativan is another one of those anxiolytics or benzos. The two non-barbiturates that I'd like for you to add off that table are Dalmane and Restoril. Dalmane and Restoril off of that table I just referenced. The CNS depressants do create that euphoric effect, that decrease of awareness and responses to sensory stimuli. They do have that relaxation, those loss of inhibitions. It also affects the body through sleep and dreaming patterns, respiratory depression, cardiovascular effects, renal function. Those are all beginning on page 467. Gastrointestinal effects, hepatic function. It affects body temperature, as well as sexual function. Now, when the withdrawal symptoms occur depends on the onset of the drug. So if you've got, like an example your book gives you is if your patient is addicted to Ativan. Well, Ativan is an anxiolytic, benzo, anti-anxiety, all those three things mean the same. And if that's what your patient's drug of choice is, or that's what they're addicted to, they may begin to have withdrawal symptoms in 6 to 8 hours because the half-life of that drug is much shorter. Right? Does that make sense? As it begins to work its way out, that anxiety, that crave, that need for the drug begins to work its way in, as opposed to a different drug that might have a much longer half-life. If the half-life of the drug is 6 or 8 hours, then they won't experience the withdrawal for a longer period of time than they will with something that's a very short-acting drug. In the case of a longer half-life drug, they may not have withdrawal symptoms for even up to a week because it takes longer to work out of his system. And then that even decreases in the 3rd or 4th week. On page 468, it talks about your withdrawal symptoms. Those are the autonomic hyperactivity, which is like sweating, pulse rate over 100, hand tremors, insomnia, nausea, vomiting, hallucinations. Yeah, who wants any of those things? So all they have to do if they're experiencing this is go get the drug and take it, right? And then they feel good. Anxiety's gone. Level of euphoria. No more hand tremors. No more hallucinations. No more my heart's beating out of my chest. So do you see the vicious cycle to fix what's going on? And it doesn't fix anything? Our CNS stimulants. Now, I have caffeine and nicotine listed on here, but your book talks about nicotine a little differently, apparently. Cocaine, amphetamines, non-amphetamines, methamphetamines. These are all psychomotor stimulants, and you'll need to change that table reference to 25-2 That table reference on the slide is 25-2, not 27. And we see all of those behaviors that are exhibited in this patient when they're using their CNS stimulants. And we've talked about almost every one of them, right? So they just kind of continue to overlap into all these areas. Crystal meth continues to be on the rise in astronomical proportions. The last statistic I had, and I apologize, I should have looked it up a little bit more recently, but in 2004, there were 0.2% ages 12 or greater admitted to using crystal meth in the previous month. Ages 12 and up. Do you know that 3% of crystal meth users are able to kick that habit? 3. And we're talking about children who have no willpower, right? At 13, they got all kinds of things to worry about. Crystal meth shouldn't be one of them. There's also, in association with this, there have also been an increase in staph infections in the past couple of years. Of course, this is with our increased meth use. Needle infections. This occurs in both your rural and your urban communities. Crystal meth is not picky. It has nothing to do with how much money you're raised around. There's an increase in brain and spinal cord work. They have to work harder, but that increase in their working harder from the use of crystal meth does not improve the performance. It just means this person who's using this crystal meth, their brain is having to work harder, but their performance is not improved. I don't think so. It doesn't talk as much about crystal meth as I would like it to, and I feel like that's very important today because you guys are going to see a lot of this in your emergency rooms. A person who's taken CNS stimulants in general, your CNS stimulants in general, they make more mistakes. They have an inability to concentrate. They're very irritable. They don't sleep well because they're taking something that's increasing their CNS. They have an increased metabolism because everything is sped up. So they lose weight. They lose a lot. They have tachycardia, hypertension, tachypnea. On your slide on psychosis, it lists paranoia, grandiosity, hallucinations, and I've added formication. Does anybody know what that is? Formication under psychosis. That's the bugs. That is what your meth patients are trying to constantly dig out of their skin. If you've seen a meth patient, they have terrible blisters and bulges and gouge marks on their arms, their face. The bugs. That's the bugs under the skin. Okay? If it's a cocaine user, they have those nasal sores. They have necrosis to the septum. Discolored mucous membranes, inflammation, nosebleeds, and they grind their teeth a lot. They will grind those teeth down. CNS stimulants affect the body in cardiovascular and pulmonary ways, gastrointestinal and renal effects, and sexual function. That's on page 471 and 472. For CNS stimulant intoxication, specific to your amphetamine and cocaine, physically, they get that either tachycardia or bradycardia. Dilated pupils are usually intoxication, but not overdose. Okay? They may be hyper or hypotensive. They may come in there sweating or freezing. So it's really hard to know exactly what you're dealing with when that patient comes in because there's no cookie cutter way of looking and assessing and saying, Yep, that's what this patient's on. Caffeine. Check your Mountain Dew bottles. How much caffeine's in there? An excess of 250 milligrams is an overdose of caffeine for your body. How many of you are overdosing? Every day. You get that restless, nervous, excited, can't go to sleep at night, can't slow down, can't shut your mind off. You got 1,000 things going through it. Flushing, sweating, rambling speech, tachycardia, can't be still. So y'all just keep a check on how much caffeine you're doing a day. Just see where you're at. Maladaptive behavioral and psychological changes will develop during or shortly after the use of CNS stimulant and intoxication. Maladaptive behavioral and psychological changes, all these things we've been talking about, will develop shortly after or during the use of your CNS stimulant intoxication. Inhalant use. This is on page 473 where it begins talking about inhalant abuse and dependence. There are just tons of things and ways that someone can abuse an inhalant. They call it huffing. There's also something that is associated with inhalants, but it's not actually an inhalant. What they do is the pass-out game, and that's not exclusive to adults. It's not exclusive to children. The goal is to partially or completely cause a loss of consciousness by intentionally depriving the brain of oxygen. Yeah. The highest targeted population of this pass-out game is 10 to 13 years of age. You know, in addition to what I have listed up here, there are just so many others. Aerosol paints, air fresheners, shoe polish, there's just so many that can be bought at Walmart and used as an inhalant. In 2008, the adolescent population that admittedly was using inhalants were more than those of the use of marijuana because they could get it easy or they could find it at home already. Put it on a towel, put it over their nose and mouth, and just breathe through it, and all they get are the fumes. Yeah, because they can find it at home or out back in the tool shed at age 10 or 13. Inhalants do cross the blood-brain barrier very quickly. Most products are, as I said, very easily accessible. The amount cannot be controlled. They don't know how much they're spraying on that towel. And the next time, how much is too much? So the amount cannot be controlled. It is potentially lethal with every use. Respiratory and cardiac depression. This is called the sudden sniffing death. They just drop dead. This is caused from asphyxiation or suffocation or choking when things start to swell. Long-term use causes organ damage, liver damage, bone marrow damage, and brain damage. So just because they can find it in the cabinet does not make it safe, and they don't understand that. Withdrawal from inhalant use is not clear-cut. We don't have a lot of documented studies and statistics on the withdrawal of inhalant use. It's highly likely that dependence, both physical and psychological, will occur. It causes central nervous system effects, respiratory system effects, gastrointestinal and renal effects. Those are on 473. The symptoms for inhalant intoxication are on page 473 at the bottom. It just lists dizziness through euphoria. But usually, if they're huffing paint, you'll see paint. Because the more they huff, the more sloppy they get with it. And I couldn't tell you how many patients we've had come in with paint on their hands or clothing And they're just as disoriented as they can be. They are high as they can be. And they've been huffing paint, aerosol cans, air fresheners.
Did you see on TV the other day where a little girl committed suicide for being bullied and that's how she killed herself?
I did catch a little bit of that. She killed herself through inhalants. Yeah. Opioid abuse. Opioid abuse are classifications of drugs that include opium or an opium derivative, and sometimes a synthetic substance is added to that. When we talk about opioids, we're talking about narcotics, right? Morphine antagonist stimulates the opioid receptors in the brain, causes all of those physiological and emotional effects that we've been talking about. Endogenous opioids are naturally occurring substances in the body. These are called endorphins. We all have them. Opioids will modify those emotions. They will modify levels of anxiety, and they will increase pleasure. The effects on the central nervous system will cause respiratory depression. It also affects the peripheral nervous system in adverse ways. It causes constipation, urinary retention, hypotension. But it also has a decrease in pupillary size. Earlier we said that CNS stimulants cause that dilated pupil. Opioids have a decreased reaction of the pupil dilation. Dilation of your stimulants that we talked about usually shows intoxication, but overdose is when the pupils become pinpoint. And that certainly applies with opioid abuse. Pinpoint size pupils are a sign of overdose on opioids. Your painkillers are also falling under this category. They act and usually have a very pleasant emotional effect when abuse of painkillers begins to happen. They decrease anxiety. And by doing this and abusing those painkillers, it increases a person's pain threshold. So when they come into the hospital in pain, it takes a lot more medication to control their pain. Someone who's been abusing painkillers for a period of time, you will end up giving them enough medication that for any other individual would definitely kill them. But it requires that type or that frequency or that amount or that dose to control someone's pain who's been abusing painkillers and has that very high tolerance and has changed their pain threshold. Demerol is usually the drug of choice for healthcare professionals. Sad. Demerol abuse is linked with doctors and nurses. It is readily available in the hospital. And because it produces that decrease in pupillary reaction, it's not easily noted. You don't easily see it. It's more difficult to detect. And Demerol is effective when taken PO. And Demerol doesn't affect the peripheral nervous system as badly as the other negative consequences we talked about. So the constipation is not as bad when abusing Demerol. So I guess that's why it's the drug of choice for most of your healthcare professionals. Opioid does primarily affect the central nervous system, the eyes, and the gastrointestinal tract. There is a table, 25-4, on opioid. Hallucinogens. A lot of hallucinogens are out there. Synesthesia. Synesthesia is listed on your slide. That is a condition in which a sensory experience is associated with one modality, and it's not the one you think. It kind of gets, the brain kind of gets crossed up. For example, your patient who is on hallucinogens might tell you they can see the music. Their senses kind of get mixed up. A sound will produce a sensation of a particular color to this patient. The other thing on the slide you might not know, psilocybin, that first line, psilocybin, those are the mushrooms. You ever heard of the magic mushrooms, the mushroom tea that used to be real big as a hallucinogenic? Yeah, psilocybin, that's what that is. Hallucinations on any of these meds become very vivid. They're very colorful. They're very real. They're all-encompassing. They're totally unaware of anything else around them but the hallucination that they are experiencing at the time. As I said, they have very overlapping senses. They don't perceive things well at all. They have a distortion in body image, a distortion in time. They have a heightened awareness that may be very terrifying. Not all of their hallucinations are pleasant. Some of the hallucinations are very terrifying. And they have a misperception of reality. So what appears to be very threatening to them may not be threatening at all. They have a psychotic type reaction sometimes. This is especially true with PCP and angel dust abuse. And they can have flashbacks. Flashbacks when they're not taking the substance. They can become very terrified and have hallucinations and begin to have effects even when they're not taking the drug. Those are what's called the flashbacks from someone who has taken the drug in the past. Severe anxiety, paranoia, and assaultiveness usually comes with the use of hallucinogens. So you as a healthcare professional have to try to be calm, non-threatening, reassuring, because you're not really sure how they're perceiving all of your actions. Overdose from hallucinogens is usually from cardiac failure and extreme muscle rigidity. What is the heart? It's a muscle. If it can't move, it can't pump. So extreme muscle rigidity and cardiac failure. There's no clear-cut withdrawal, especially since we can see flashbacks from the PCP and the LSD much, much later on. So there's no real clear-cut when does withdrawal start or end. Designer drugs began to flood the population in the late 90s and then exploded in 2000. Designer drugs were being sold over the internet, and they were changing the names of them a little bit, changing the chemical component just a little bit, or changing what they listed as the use for the drug so that they could get past FDA regulations. People would begin to buy even something that was listed on the internet as not for human consumption and then would make it into a drug. And that's the way the makers could sell it over the internet without the FDA getting involved. Because they didn't want to adhere to the FDA standards and have to, have that research done on their drugs. They list them as psychoactive substances such as plants or synthetic substances. The makers of these drugs do alter the chemical formulas, but the drug itself still gives the same effect, even though they've altered the substances a little bit. They just do that to get by the drug laws that are put in place to protect the population. The Controlled Substance Act is a law that says it is illegal to manufacture, sell, or possess chemicals similar to any of those in Schedule 1 or Schedule 2 drugs. That's the Controlled Substance Act. It says it is illegal to manufacture, sell, or possess chemicals that are similar to Schedule 1 and Schedule 2 drugs. So, they alter their formulas. They alter what they say it's used for. They change it synthetically a little bit. And they sell it for a different use over the internet. As I said earlier, where there's a will, there's a way. Cannabis, marijuana, hashish. As I said, it is considered by the general population, not just your children, but by the general population as a safe drug of choice to use. Does it have medical effectiveness? Yes. Cancer patients do benefit from it. It helps to control pain and increase their appetite because of that side effect of the munchies. Overdose occurs when you get too high. Well, when do you know you're going to get too high? You don't, till it's too late. There is no way to clear-cut say these are the things that will happen before you get to this bad area. So you don't know until it's too late, and the point of overdose is present. Dilated pupils, reddened eyes. These are the telltale signs. Dilated pupils and reddened eyes are the telltale signs of use. Now, long-term use does cause respiratory problems, immune system suppression, sexual hormone changes, and what is called amotivational syndrome, like no motivation, no clear-cut withdrawal. Usually when there is a withdrawal or a death associated from cannabis use, it is respiratory or cardiac depression. Long-term use causes organ damage, liver, kidney, bone marrow, and brain. And psychological dependence is likely after the first use. Techno, club, and rave drugs. Raves are those large all-night dance parties usually held in a warehouse somewhere. They're highly publicized. They're marketed to your younger children. Sometimes they're held in open areas like a closed-down railroad yard, something like that, that features an area for a high generation of population to be there. High volume of pulsating music. That's what's known as the techno or the house music. Rave clubs got their start in England in the late 1980s. They're known for their music scene and drug scene. It seems very attractive to adolescents from the age of 13 to young adults up into their mid to late 20s. That seems to be who participates. Ecstasy is a hallucinogen and a stimulant. Ephedrine is a stimulant. Ketamine is a hallucinogenic. It's actually an animal tranquilizer used by vets in pet surgery. When someone uses ketamine to get high, they tell you that the use of ketamine is similar to the use of PCP. That's how they describe it. GHB is a central nervous system depressant. It is also what is called the date rape drug. Rohypnol, date rape drug. Methcathinone is a stimulant. LSD is a hallucinogenic. And then the mushrooms we talked about, they are hallucinogenics that include illusions, hallucinations, distorted perceptions, just like all of the other drugs that we talked about. Just a mushroom. That's what someone who's using it for the first time, it's just a mushroom. It can't hurt you. It grows in the ground. It's natural. It's organic. I do know of a young man who, very good student, very smart, did very well in school, very likable, athletic. High school graduation, he got talked into, with his peer pressure and whatever, to trying some of those mushrooms that were boiled into tea. He has been broken ever since. I see him periodically as a patient, and that's been 25 years ago. One time. He's broke, y'all. It comes in the form of tablets. You can mash them up and form them into tablets or powder. The person experiences what they call trips or episodes, where they lose contact with reality. They have psychotic episodes, convulsions, flashbacks, and possible death. And then your methamphetamine is also a stimulant. Okay, let's take 5, and then we'll come back and pick up with heroin. We will start heroin. Okay, we're going to talk a little bit about heroin because it's not listed as a specific topic in your book. Again, the pinpoint pupils are a sign of overdose for this. The rush that it talks about feeling takes less than a minute to hit, and it produces itself as an intense physical pleasure. Heroin can also be liquefied. It can be put into a spray bottle. They can spray it in their nose. You can use it subcutaneously, but this also has statistically increased the number of HIV and Hep C cases. Heroin can be done through a thing called skin popping. This is an injection. It also increases skin infections, constricts the pupils, respiratory depression, and skin flushing that is apparent in the face and neck. It's highly addictive. It does easily cross the blood-brain barrier. It causes a sustained high because the chemical effect of the heroin gets trapped in the brain for a prolonged period of time, so it causes that prolonged feeling of high. It still affects the physical, but there is such a sense of euphoria that they don't notice or they don't care when they're using. This increases their risk for overdose drastically. Respiratory rate, less than 12. Symptoms of withdrawal. They usually will put some alterants. These are the additives that they put in with the heroin to cut the purity of the drug down some. And withdrawal begins in 4 to 12 hours, but can take up to 24 hours with that chemical trapping of the heroin in the brain that I talked about. It causes that prolonged effectiveness, so withdrawal sometimes can be prolonged. It usually takes 4 to 12, but it can take up to 24 hours. The withdrawal will peak in about 24 to 72 hours, and that's as bad as it's going to get, but then that can last up to a week. The peak of withdrawal can last up to a week. Most say it is about a 5 to 7 day average for withdrawal symptoms. They have a lot of lacrimation, watering of the eyes, and a lot of rhinorrhea, which is the runny nose. They can withdraw on their own. They don't have to come in for medical treatment, but withdrawal is rarely fatal, but is extremely painful for the patient. The old term, kicking the habit, you've heard that maybe in the past, kicking the habit. The reason that term came to be is because they have such profound muscle spasms in their back and legs. They will just go stiff and straight. So the old term, when someone used to try to withdraw off of heroin and they had those terrible muscle cramps and their legs would just go stiff and straight, that's where the kicking the habit term came in. The signs and symptoms are usually going to be related to the degree of dependency, meaning how much have they been using and how long have they been using, and then whether or not they're trying to titrate off of it or go cold turkey. These listed on the slide are what your patient will go through when trying to come off of the heroin use or the heroin addiction. The leg spasms and the back spasms that can cause the patient to just contort into different positions. Piloerection listed on the slide, that is goosebumps or goose flesh, profound, just crawling of the skin, goosebumps. They will experience an elevated pulse and temperature. The cravings for the drug are very profound and very unpleasant. The muscle stiffness is very painful. Sometimes in treatment measures, if we are treating the patient, we're going to treat what the symptoms are, and we're going to give supportive measures. Clonidine helps with the vomiting and diarrhea that the patient will experience during withdrawal. Clonidine helps with the vomiting and the diarrhea. Buprenex and Narcan will help with the actual detox process. Remember earlier when I said sometimes we can give a different drug that will go in and kind of mimic the use while we're trying to titrate someone off, maybe a safer drug, a more controlled drug that we can use to try to help with detoxing in the process. Well, Buprenex and Narcan help with the detox process off of heroin. And what about our meth user? Weight loss. The center of the face and truncal area become very pale with use. They have a central pallor about them. They sweat a lot because of the increase in their metabolism, so they don't smell very good. And they have no desire to take showers or to take care of their hygiene needs. That's not as important as the drug use. They can inhale meth, inject it, they can eat it. They say it's similar to cocaine, but it lasts a little bit longer than the cocaine rush, 6 to 8 hours. And once they begin using, they just continue to use until they can't feel an effectiveness anymore. And then they have that period of days that have gone by. And then they tweak until they crash. And the crash is usually profound and hard, and their body has just reached the point of non-existence. Just like when you drive your car with that light on, eventually it's going to quit. Well, they can stay up for days, not eat, not sleep, not bathe, not take care of themselves, but when that body physically quits, they crash. That's the crash. And they will sleep like a bear hibernating. It causes damage to their teeth. They have very poor dentition. They have those bugs under the skin, that formication, and they dig at them. They try to get whatever it is they can feel under their skin out. They just know it's there, and they'll dig holes in their arms, legs, face, trying to get that out from under their skin. They have rapid eye movements, rapid speech usually. They have uncoordinated, rapid, quick body movements. They just look very uncoordinated as they move. 4 years. 4 years of use in that picture. There's your typical meth user. You see that central pallor, those red irritated eyes. He's just emaciated and tired and give completely out. His body is just to the point of exhaustion. Here's 10 years of meth use. The very first picture and the picture right under it, that's the death picture. So it goes straight across and then down and back over this way. So look in 10 years. In 2010, there were 8,000 meth labs that were seized nationwide. And out of those 8,000 meth labs, 3,300 children were removed from the premises. So we haven't, as healthcare professionals, begun to see the effects on those children yet, but we will. Because that residue is everywhere in the homes. People won't even go in to burn down those homes without respiratory equipment and biohazard suits, and yet these children were in those homes crawling around, picking up things, touching things. So we haven't yet begun to see the consequences of those 3,300 children that were removed in 2010, but as a healthcare professional, you will. These family patterns, I could not find them distinctly labeled in your book, but they are important, so we are going to talk about them. In a family of abuse or addiction, the family members within that unit will begin to assume different roles. And that's what we're talking about, those roles that are patternistic for those families coming from abuse. The chemically dependent person, well, this is the one that usually causes all of the chaos. They're usually very manipulative, charming, controlling, and hostile. If you've had any personal dealings with someone who was chemically dependent, does anyone think that that accurately describes your experience with someone who was chemically dependent? They can come across very charming, very manipulative. Remember we talked about in the beginning how creative they have to be to come up with the different ways to use to identify their behavior and to rationalize their behavior, right? For a while, man, they got you convinced. You're fooled. And then they get a little hostile and very manipulative. The charm begins to wear off a little. You have your chief enabler. The person who assumes the role of family pattern as chief enabler is usually the person that is the closest to the chemically dependent person, to the abuser. The chief enabler has very good intentions. They have the best intentions because they're the person closest to the abuser. They love the abuser, right? They do this thing where they alternate between periods of rescuing the abuser and then enabling the abuser and then blaming the abuser. They help them out, then they kick them out, then they bring them back. They will begin to make excuses for the abuser and for their behaviors. They'll tell lies for them. They'll pick up the slack. They'll take on more responsibility so that things don't go undone, so that people outside of the home don't really see what's going on inside. They really think that they're helping. This chief enabler really thinks that they're holding the family together and they're doing their best. Then you have the family hero. The family hero is the one who feels like they need to fix everything. They need to make everything run smoothly. They feel this enormous responsibility to overcompensate, overachieve, make sure that things get done, keep the family working from the outside onlookers. That's our family hero. More often than not, the family hero becomes one of the children in this family unit. Now, every family, obviously, is not going to have every one of these. If they only have one child, then they can't have every one of these going on. Or, there's a blend and an overlap. But if there's a scapegoat, someone who takes on the scapegoat role, again, usually a child, they get attention through acting out. They're feeling very anxious. They don't like what's going on because the abuser is either an older sibling or a younger sibling or a parent. So they don't like what's going on. They feel a lot of resentment, anxiety, tension, and anger, and they act it out. And they get attention for acting out all of that, which diverts attention away from the abuser. This is usually someone that gets labeled as the bad kid or the rebel. Sometimes you'll hear, well, they're just a product of their environment. They're angry and they're hurting and they're acting out to get some attention. Then you have the lost child. If there's a lost child role, this is the one who isolates themselves. They just feel like they've been forgotten. They're not important. They're emotionally detached. They're sad. And they're often angry too, but they don't act it out. They just hurt. They're very withdrawn. They take it out on themselves. And another role that might be played is the mascot role. Now, the mascot role is a whole lot like the family hero. They're very similar, but a little bit less intense. They try to deflect situations with humor in an attempt to decrease the stress. You know, when things get really intense and hard to handle, then they'll throw out a joke or some kind of funny, off-the-wall, inappropriate kind of humor because they're feeling stressed, and they deflect it with humor. They act silly or foolish whenever they're uncomfortable. They want to make everything okay. They want everybody to be happy. They want to please everybody and keep things pleasant and light and upbeat. Well, if you have an abuser, a drug abuser or a chemically dependent abuser in the family, things are not always light and upbeat. This family pattern, any family unit experiencing this, they also have a lot of conflict. They try to hide the true picture. The family is, in general, socially withdrawn because the kids don't want to bring friends home. They never know how whoever this chemically impaired person is going to act, whether it's an older brother or younger sister or it's one of their parents. So they don't have a lot of spend the night company. They don't participate in a lot of school activities because they don't want their parents coming and showing up like that. So as a family unit, they're generally socially withdrawn. All the family members do feel some level of guilt, remorse, anger. They all have mistrust issues. The goal for this family and for any of these roles that I've discussed is to educate them, teach them how to handle it with positive outcomes. As I said, that chief enabler, they really think they're doing the right thing, and to the point that they can't handle it anymore. So we have support groups, we have education, and for that chemically dependent person, the only thing is abstinence from the drug. That's all that's going to work. And until we teach everyone in that family that nothing you're going to do, no matter how good you can be or how bad you can be, is going to change what's going on, until they choose to stop using, you can't change it for them. So that's very important when you're the healthcare worker who's giving those support groups and encouraging that and trying to be helpful. The chemically impaired nurse begins on page 497. Yes. The chemically impaired nurse may be your very best friend that you've worked with for years and years and years. Y'all go on family vacations together, but something has changed. And now you realize that your very best friend and most close confidant may have a problem. And you go through an ethical dilemma. Loyalty to your very best friend who's been your friend for years versus patient safety. What might be noticed about this employee is a high absenteeism, or they may rarely miss work. Why would that be? That is the access to the drug. They may volunteer for extra shifts. They may be in the hospital when they're not working, just hanging out, just stopping by. Whenever they work, there's an increase in the need to waste drugs. You know how we have to have someone come in and watch with us? But we don't always see what that drug is that we're wasting, do we? Sometimes it's so much just already filled and ready. Hey, I just need to have you come in here and witness this wasting with me. I only needed 1 milligram and it comes in 2, so I'm going to squirt this other 1 milligram down the drain. Are you positive that's 1 milligram? Not unless you watched them draw it up. But you signed with them to waste it, right? So if you notice with that one nurse, there's always a lot of drugs to be wasted. There's always a lot more on her shift or his shift. There's an incorrect narcotic count after they've given meds. Narcotics being used more. You know, if you come on shift and Tylenol controls the pain for the patient that you just had, and then the next day you notice that this individual nurse that we're talking about worked and it took a narcotic to control their pain. Wow, is their pain getting that much worse? And you go in and you talk to them. No, the pain's not a whole lot worse. And, you know, I feel like I'm about the same or I'm getting better. Narcotics are off. But they're signed out for this patient. But Tylenol's controlling the pain. What do you think? They're signing off for narcotics that they're not giving the patient. They're taking them. But you see that it's a higher record of narcotics used when that nurse is working. Poor concentration, difficulty meeting deadlines, inappropriate responses, and poor memory and recall. Or they're signing out these narcotics to give to the patient, and the patient continually reports their pain is not being relieved. They are not getting any relief. They just gave you morphine, Miss So-and-so, such and such. They just gave you Demerol. I'm hurting so bad I can't stand myself. Are you positive they got their Demerol? Do you see that beginning to be a pattern every time that specific nurse works, that none of his or her patient's pain can be controlled? It's likely what the patient is receiving is saline or water and the narcotics being used by the nurse. But you notice that pattern, that every time that nurse works, their patients hurt. They can't get any relief. Those are things you want to look for. Volunteering to be the med nurse. Like I said, staying around on the unit even when they're not working. Just hanging out. Emergency departments and ICU, oncology units, those are more frequently the units that you'll see this happening because they have the higher potency of drug relief, right? The higher levels of narcotics and pain relief. Problems with relationships, irritability, isolative, elaborate excuses for their behaviors. They will explain away everything. If you catch them on something but you're not sure yourself, I promise you they will explain it away to you and in a way that makes you think, oh, wow, I hate that I thought that about them. Until it happens the next time. Someone who used to be very good at what they do and used to run circles around you and you never knew how they were so good at their job, not so good at it anymore. Things are going undone. Patients are complaining. Patients are left without their care being done. For years, the chemically impaired nurse was protected or even promoted or transferred or ignored or fired, but not treated. Denial is still the strongest argument for dealing with a substance abuse problem. The state board's response, not so much denial. We need to treat this chemically impaired nurse. We need to offer assistance. The state board may deny a license, suspend the license, or revoke the license based on a report of chemical abuse by another nurse or by a healthcare professional. So just on the report, before we can do the investigation, your license could be suspended, revoked, or denied. Okay? So with all the things I just said, don't make a report unless you have some reason to believe patient safety is being compromised, right? There are diversionary laws that allow the impaired nurse to avoid disciplinary action by agreeing to seek treatment. If they agree to go into a treatment, sometimes they can avoid legal. Whenever they're suspended and going through those treatment protocols, they have to have a successful completion of an inpatient or an outpatient group or an individual counseling treatment program. They have to do it. They have to go through with it. They have to participate. They have to show up. They have to have regular attendance in their groups, whatever it is they're doing, or their 12-step program, or whatever their treatment is. Random negative drug screens will be drawn. They have to have employment, not as a nurse giving meds, but an employment and a volunteer activity record going on. They have to prove that they can get out there and can meet responsibilities, but they're not going to be giving meds. May not even be working in a medical facility during that suspension time. Peer assistance programs are in place. These are the programs that serve to assist impaired nurses to recognize their impairment, obtain necessary treatments, and regain their accountability within the profession. You are responsible for reporting to the appropriate chain of command if you suspect that there's a chemically impaired nurse on your unit. Confrontation usually results in hostility. Plan for it. Accusations are not taken lightly. When you accuse someone of being a chemically impaired healthcare professional, it is going to be looked at very seriously. So you need to have some things in place if that's what you're going to do. Document the times that you thought something was off. Document the behaviors so you can show some trends or patterns. Document your observations, and when you have enough, take it to your supervisor and say, I didn't want to say anything until I was sure, but every time this person works, this happens, or these are the complaints, or this is what I see, or the narcotics count is off.
So why are you letting your employee, do you not take, like we did here, take drug tests every so often to know?
A lot of employers have that in place, but it's expensive, and a lot of employers don't.
So they don't unless there's a reason to suspect.
Most of the time, a large facility will not do random drug screens as a policy in that facility for every employee. Most of the time. The research evidence says that a problem exists in a chemically impaired nurse when the problem usually existed before they became a nurse. Most of the time, they will tell you that they began to use during nursing school. What about that? Huh. But rarely does the problem start after years of licensure. It's usually a problem that was already there, or an underlying problem, or something they were dealing with already prior to getting their license. But after years of licensure, it's more rare that it occurs then. All right, I'm going to tell you what I'm going to do. Codependency begins on page 498 in your book. Codependency is an unhealthy dependence on another person that often leads to an over-involvement and a loss of personal balance and power for that person. They begin to act almost compulsively. They rarely show emotion. They are a little bit of a perfectionist. They have very blurry boundaries. Sometimes they use what's called double standards with good intentions. They've learned this very poor, dysfunctional pattern in their relationships because oftentimes they are a victim of low self-esteem. They feel powerless. So they get a sense of control by giving up of themselves. And then they become very suspicious of others who seem to only want to do for them because they're not used to that. They push themselves to very unrealistic expectations and achievements and accomplishments. Someone who is codependent will blame themselves for their partner's substance abuse. So then they can rescue them to blame them again another day. They will enable the partner to be able to use by making up all the excuses, picking up the slack, and they will dwell in controlling the whole situation. They'll drive themselves just crazy trying to control the entire situation. The codependent nurse is on page 499 in your book. The codependent nurse experiences certain characteristics associated with codependency and with the nursing profession. They tend to put the needs of others above their own. Even when there's a nursing shortage with an increased number of patients that they're responsible for and a decrease in pay scales, they will continue to work as a nurse, as a healthcare provider. Usually this healthcare provider was raised in a home with a chemically dependent person or a dysfunctional family process. They are experiencing unresolved codependency issues from childhood usually, and these issues are then activated by the nursing profession because they still have that desire and that overwhelming need to fix everyone. The codependent nurse will strive for unrealistic goals. because they get self-worth from caring for others and for meeting the needs of others and by feeling that they are needed. They will do whatever they have to maintain harmony and to feel control in all of their work settings. They have a very high risk for emotional and physical burnout. So what do we do for these people? On page 499, it talks about treating codependency, and there are 4 stages. The 4 stages of codependence are, number 1, the survival stage, where the person must let go of the denial that a problem exists, and they must begin to realize their own limitations. Stage 2 is the re-identification stage. This is where the codependent nurse becomes aware of true self and true actions. They accept that they have an issue with codependency. They take responsibility for their own behaviors, and they accept their own limitations. This re-identification stage requires a willingness to change the behaviors in the past. Stage 3 is the core issues stage. This is when it is time to face the fact that relationships cannot be managed by force of will. Relationships require independence and autonomy on both parts. The codependent person has to understand and acknowledge they cannot control the situation any longer. So therefore, the goal for this person is to relinquish that control and to detach from their struggles that they face that are beyond their control. Stage 4, the reintegration stage. This is when they experience self-acceptance and that willingness to change gives over. They give up power over others and begin to reclaim their personal power. They begin to reclaim who they are and identify with what their needs are. Self-help groups are good for this person to continue to maintain these new behaviors. When we talk about substance abuse, substance disorders, there are some special populations. Pregnancy being one of the special populations. This is specific to the fetus being exposed to any type of substance during pregnancy. With central nervous system damage, it usually occurs between the first 2 to 8 weeks of pregnancy when the mother may or may not even be aware that she is pregnant yet. Substance use can cause an alteration in critical brain development. As we said earlier, there is no safe level proven for even any alcohol intake during pregnancy. So any other drug or substance is also, there are no proven levels. Some medications will be given during pregnancy that are recommended not to be taken during pregnancy, but they're closely monitored, and it would be a medical need for that pregnant mother. Fetal alcohol syndrome we talked about already. Opioid withdrawal from any type of opioid or narcotic. We really don't encourage the patient to go cold turkey or to stop the intake of the drug immediately. This does increase the risk of a spontaneous abortion for this person, especially during the first trimester if they find out they're pregnant and they immediately stop using the drug. As I said, it does increase the risk of a spontaneous abortion during the first trimester. It can cause premature birth in the 3rd trimester. Usually the treatment is with a narcotic methadone. Methadone is also a potent, long-lasting opioid painkiller. It is switching one drug for the addiction of another opioid. But the methadone prevents full withdrawal symptoms from happening. Primarily, it prevents the withdrawal from heroin. The benefits of methadone outweigh the risks in pregnancy of stopping cold turkey or from going back to the choice of drug opioid that they were using in the beginning. The side effects of methadone include nausea and vomiting, severe constipation, It is believed to provide a source that is safer to obtain for the mother without exposing the mother to any bloodborne pathogens in the event of needles. The babies are still born addicted to methadone, and they will still go through a withdrawal syndrome, the neonatal abstinence syndrome, after they're born, to a mother who is trying to stop a narcotic or an opioid abuse. That page number for fetal alcohol syndrome is incorrect on the slide. The page number for fetal alcohol syndrome is page 464. When we talk about a dual diagnosis, this is two unrelated diagnoses. The presence of a substance abuse disorder and any other mental or medical or personality disorder is usually the combination making a dual diagnosis. Self-medicating with the medications for a mental illness. Patients with schizophrenia may require a non-judgmental, trusting approach from the healthcare provider. Remember that they may have schizophrenia and they may be self-medicating with street drugs to try to get rid of the symptoms of their schizophrenia. So there they have an abuse problem and schizophrenia, which leads to the dual diagnosis that we're talking about. And remember, when you are assessing a patient for any drug use, they're usually not going to be honest with you about the extent of their use. Hospitalized patients, hospitalized substance abusers, are more often there for general medical issues than they are seeking treatment for their abuse issues. Understand that they can experience withdrawal unless similar meds are given to them. They will require an increased dose of pain medication if they've been taking pain medications as their choice of drug to abuse due to the tolerance. Also keep in mind that they're going to have difficulty with liver metabolism. Their liver metabolism is going to be much quicker if they've been using pain medications. Or there may be liver damage, and it may not metabolize as well for some medications. If the abuser's drug of choice was a CNS depressant, then the withdrawal effects that you see will be the opposite. If the abuser's drug of choice was a CNS stimulant, then the withdrawal effects that you will see will be the opposite of the stimulant. Overdose from a chemical substance. General measures for substance overdose include gathering a history of the drug abuse, identify the drugs, the amounts, get a drug screen, monitor the patient's vital signs, level of consciousness, get an EKG, reduce the absorption. This is usually from inducing vomiting or emesis, gastric lavage on the patient. Absorbitants, this is usually giving the patient activated charcoal to help reduce the absorption of the drug. And hemodialysis is sometimes required to help filter the blood and the chemical substance. May require restraints for protection and safety. They may also require medications according to what type of withdrawal symptoms that they're having. Seizures, anti-anxiety meds, antipsychotic medications. We're going to treat the symptom. Some specific measures. The antagonist attempt to counteract the drug's effects. It resists or opposes the drug's action. Opioids, specifically Narcan, can help with the withdrawal symptoms. Hallucinogens require the nurse to have patience to wait on the individual to, quote-unquote, come down off of the episode that they're having. Sometimes you may talk them out of their hallucinations and reassure their safety. But remember, they are very excitable. They're very overactive. They have intense perceptions that are not always accurate. Continually require reassuring for their safety and their environment. An agonist, remember, an agonist binds to receptors and stimulates the receptor function in the brain, thereby inhibiting the drug action. So for opioids, you have agonist versus antagonist. Your methadone that we talked about is an agonist. It's also used when there's a high likelihood of relapse after treatment. It's one of the measures used to limit abuse. Naltrexone or Narcan is an antagonist. It is used when the patient is opioid free. Medications for CNS depressants, benzodiazepines, including Librium and Ativan. Give them a quiet, non-stimulating environment with soft lighting to reduce shadows. This will also help to reduce their paranoia and their illusions and hallucinations. Remember, they do have an increased startle reflex. Their perceptions are altered. Take frequent vital signs, evaluations of control of the medications that you're using to make sure that we are going in a positive outcome direction. Some other meds that might be used are thiamine, which is your B12, and it will help to prevent some of the neurological complications, especially the encephalopathy. A multivitamin may be used, especially B12 and folic acid. Also, seizure medications may be required. Phenobarbital is your seizure med. For sedative, hypnotics, and anti-anxiety treatments, these are gradual withdrawal with a similar drug used, phenobarbital or a long-acting benzodiazepine. For opioids, methadone, clonidine, and buprenorphine are used to help with withdrawal. Opioid addicts have a intense hunger for the drug, so methadone and clonidine will help with the nausea and the vomiting, and it also helps to relieve the intense preoccupation that the client has with the drug. LAAM is LAM, and it is an alternative to methadone that can be used. It has a different chemical makeup but acts in the same function as methadone. LAM is a synthetic opioid used in the treatment of opioid addictions. It was approved in 1993 by the U.S. Food and Drug Administration. While LAM is considered to be similar to methadone in its effectiveness, it does include an analgesia, sedative, and respiratory depression effects. LAM is indicated for use in the treatment and the maintenance of opioid dependence. It's used most often when patients don't benefit from other replacement therapies such as the methadone or the buprenorphine or the clonidine. Treatment measures for amphetamines, cocaine, may require antidepressants, and you might see the treatment for amphetamines and cocaine use being anti-Parkinson drugs. The anti-Parkinson's drugs are used because amphetamine and cocaine produces symptoms that will mimic Parkinson's patients and Parkinson's movements. So an anti-Parkinson's drug, maybe Symetril or Parladel, may help with some of those side effects of the amphetamines, cocaines. Benzodiazepines or anti-anxiety, anxiolytics can help to relieve the crash off of the amphetamines and cocaine. Treatment in your alcohol abuse. Antabuse is on page 501 in your book. In addition to everything that is on the slide there for you, you need to know that you're only going to use antabuse as a deterrent to drinking for those persons who are truly motivated to stop drinking. They have to be motivated and committed to stopping and agree to take antabuse. There is an antabuse alcohol reaction that will occur within 5 to 10 minutes of taking alcohol into the system if they are already currently on antabuse to stop drinking. So you can't administer antabuse to anyone within 12 hours of alcohol intake. Some of the reactions between the antabuse and alcohol can be very severe, even life-threatening. Symptoms of the interaction initially might be flushed skin, a throbbing headache, throbbing of the neck veins, vomiting, sweating, hyperventilation, respiratory depression, weakness, blurred vision, confusion, and those symptoms that I'm talking about now occur at 50 milligrams of per deciliter of alcohol. So if there is more consumption of the alcohol, it's going to worsen with the increased level of alcohol. It can lead to severe reactions that are listed on the slide, and can occur at 125 to 150 milligrams per deciliter of alcohol as a blood alcohol level increases. Also, educate your patient if they are going to stop taking antabuse. The pill is still very sensitive in the system, and it stays in the system for a while, and your patient could continue to have an antabuse alcohol reaction even up to 2 weeks after stopping the antabuse. To take antabuse, as I said, the candidate must be committed to abstinence. For nursing considerations, you have to teach the patient a lot about taking the antabuse. They have to wear a medic alert bracelet because it can be a possible emergent situation if an alcohol and antabuse interaction occurs. Your patients don't usually think about what all contains alcohol, so you have to teach and educate them to read labels and to avoid any sources of alcohol, whether that's food, over-the-counter medications, including aftershaves and some colognes, certainly rubbing alcohol, cough medicines, cold preparations, vanilla extract, nail polish removers. They can have a reaction to an alcohol swab rubbed on the skin, even if they're on antabuse. So we want to teach them adequate nutrition. They may require IV therapy if they have an interaction. They need high carbohydrate meals for processing and metabolism. And they may require an antiemetic if the nausea and vomiting is severe enough. Some additional interventions for this chemically addicted person. Family therapy concepts. Without change, without teaching new behaviors and new interventions, the old patterns of behavior are likely to surface. Addiction is a family disease. We talked about all of the family roles that can be assumed in a family unit where addiction is present. Without educating the family members might expect the patient to be able to just return to normal after they're shortly out of therapy and trying to regain their life. But then by putting that pressure for the patient to just return to normal and to start functioning as normal as soon as they return from treatment or therapy, it is this pressure from the family and this stress that can actually cause the patient to then return to their old maladaptive behaviors. So that's why you have to educate all of the family members. Finally, group therapy is very beneficial. Your patient can find allies in group therapy. Some examples are Alcoholics Anonymous, Narcotics Anonymous. Those are just a few. They tend to benefit from these group therapies because allies will take care of each other. Old members confront the new members to help give insight and to actually have been where the patient has been so they can help understand. Relapse prevention is also very important to teach. So many of our patients do experience relapse. We want to help the abuser develop strategies to avoid relapsing. Identify the thoughts and situations that put the patient at a greater risk. The acronym HALT has been used. We educate the patient not to get too hungry, too angry, too lonely, or too tired, because that's what puts them at greater risks for using those maladaptive behaviors and going back to the old patterns of behavior. There are 12-step programs. Permanent abstinence is the only option, but the 12-step programs help to guide and maintain this abstinence. The The core concept is submitting to a higher power. That's what is used in the AA core concept. Sponsors include social, personal, and individual support systems and settings. There are open meetings. There are closed meetings. There are meetings for teenagers, adults, married, single, adults of children that were raised in alcoholic homes with alcoholic parents. There are a lot of different self-help groups and community resources. Some final points to take home with you are that many addicts go through a grieving process when they come off of the drug. They actually go through a period of time where they miss and regret and grieve for the drug use. So when they are successful in becoming recovering addicts, they then will desire a respect for the courage that it has taken them to conquer and to kick the habit. And it needs to be said that they deserve that respect after they have gone through the program and they have changed their behaviors and they continue to become active participants to remain abstinent from whatever drug it is that has ruined their life to this point. So they do deserve that praise and recognition for that. It's not an easy task. This concludes Chapter 25, Substance Abuse Disorders. Thank you.